Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned professor, Dr. D.N.B.M. Prasad. Sir is MD Medicine, DNB Medicine, DTD-CD, DNB Respiratory Medicine, DM Pulmonary Medicine, MNAMS, European Diploma in Adult Respiratory Medicine, FICP, FNCCP, FCCP USA, FRCP Glasgow, FRCP London, Senior Consultant Pulmonary Medicine, Interventional Pulmonary Sleep Medicine at Chinmay Mission Medical Hospital, Bangalore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is idiopathic pulmonary fibrosis, current status. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Good evening, my dear doctors. Thank you for the wonderful introduction about me. First of all, I compliment IGCP for giving this platform to disseminate knowledge on common and interesting topics. And the topic which has been chosen today is management of ILD, current concepts. Interstitial lung disease, I am sure you must have come across and managed in your clinical practice. And it is becoming more common nowadays. And one should have a clear insight into this problem to have a comprehensive and optimal management of this condition. Just to give you some brief idea about what is interstitium and interstitial lung disease, I would like to emphasize that interstitium is the space between the alveoli and the pulmonary capillaries, and it has got connective tissue, matrix, and also immune cells. So it has a very important function to subserve. It tries to maintain the configuration of the lung during various phases of respiration, and also has got cells which can protect the lungs from any external onslaught, and also has got functions of releasing certain substances which help to carry out the metabolic functions of the lung, and also which also helps in protecting the lung. So what are the immune cells which are present in the interstitium? They are the macrophages, the fibroblasts, and the myofibroblasts. And the matrix is the one which is a supporting structure, and it has got proteins of collagen and non-collagenous substances. There's fibronectin. So this is briefly to tell you about the interstitium. When I was doing my MBBS, when I was a postgraduate at the time, there was a very limited understanding of interstitial lung disease, a disease which affects the interstitium. And the interstitium, nobody saw what constitutes interstitium. And then we had a broad umbrella of diseases which all lead to ILD. So that was an understanding of the disease at the time. But then much has changed thereafter. Today, interstitial lung disease is considered as a heterogeneous condition, and the term is an umbrella term used for describing large group of diseases, the more than 200, that have in common the fibrosis of the lung. So there's a fibrosis of the interstitium. There's a fibrosis of the lung. And the most important umbrella variety of ILD is idiopathic pulmonary fibrosis. As the name suggests, idiopathic means we don't know the etiology. And under the umbrella of ILD, we have idiopathic interstitial pneumonias. And one of the idiopathic interstitial pneumonia is idiopathic pulmonary fibrosis, which is characterized by diffuse which is characterized by relentless fibrosis of the lung. And so that is the hallmark feature of idiopathic pulmonary fibrosis. And most of these ILDs, the symptoms are very non-specific. Initial stages, they come with mild cough, they may come with some tiredness or breathlessness, mild breathlessness, and often one may term them as respiratory infections, bronchitis, or asthma, and they are often undiagnosed. So there is always delay in the diagnosis of these conditions. Many times, it may be the first manifestation of a connective tissue disorder. You all know connective tissue disorder, rheumatoid arthritis, systemic sclerosis, then polymyalgia rheumatica, systemic lupus erythematosus. So many times they may not have the classical symptoms of SLE, but they may present with the ILD as the first manifestation of the disease. Now, ILD is very important basically because it's a progressive disease and is highly debilitating. And mortality in some of these ILD is very high and it can match malignancy. Even malignancy can be cured, but ILD may not be. So that is the importance of ILD. And when a person has got IPF, idiopathic fibrosis, the life expectancy is 3 to 5 years from the time of the diagnosis. So that is the gravity of the situation. Now, the evolution of interstitial lung disease, it started almost, in the 17th century. In 1713, Ramazzini, an Italian occupational physicist, a physician, in fact, he described respiratory failure, right heart failure in patients or in subset of population who were exposed to the grain, who were exposed to who are the grain workers, who are doing in milling and all these things. So they had the problem of cough, breathlessness, progressive, and then edema and right heart failure. And thereafter, a large number of occupations were associated with these type of symptoms. And Ramazzini can be considered as the father of occupational medicine. And thereafter, people try to understand the pathology, the pathophysiology, and the radiology of this particular condition. That all happened because of advancement in CT scan and the imaging. So, and also in the histopathological studies. So, in 1892, Osler considered this type of interstitial lung disease, cirrhosis of lung. You know, cirrhosis is a fibrosis of the liver. Similarly, the lung also is totally fibrous, solid-like structure, and that is what Osler observed among ILD patients, and he described them as cirrhosis of lung. It is Hamann and Rich, who actually described the acute presentation of ILD, interstitial lung disease. They came with rapidly progressing respiratory failure. And so this was in the year 1935. Then people gave different, terminology, non-infective variety. So they call it an interstitial non-purulent pneumonia. You see, pneumonia is caused by bacteria. But here we have a pneumonia which is not due to bacteria. It's not due to infection. And after you know that COVID is also one of the causes of interstitial lung disease. Earlier in the definition of ILD, the infection was excluded, malignancy was excluded. Today we include all these conditions, but the end result should be fibrosis. So then understanding of the pathology in 1964 by scanning, he called that cryptogenic fibrosing alveolitis. Then it was Lebo who actually, who laid the foundation for the various subclassification of ILDs and the pathological classification of UIP, usual interstitial pneumonia. It is the common presentation of ILD, therefore it's called the usual, but it is fibrosis of the lung. And here he described, various conditions like lymphocytic interstitial pneumonia, bronchiolitis obliterans with organizing pneumonia. Then he called usual interstitial pneumonia, non-specific interstitial pneumonia. So he tried to classify based on the pathological features. Then the CT scan tried to, refine the definition of the ILD. The bronchoscopy, especially Turner Warwick in the 80s, did a lot of lavage in these cases to identify what was responsible for this fibrosis and to diagnose early and the late stage of fibrosis. She used the fibrotic bronchoscopy and liquid biopsy of the lung, that is bronchial lavage. So it is the CT scan which was discovered by Hounsfield, which finally led to a more understanding of this disease. Then the ATS came out with various statements, and the ATS statement in 2002, where the classification of IIPs, that's the interstitial idiopathic interstitial pneumonias, into different subcategories, and differentiating this idiopathic variety from diffuse parenchymal disease, which can be caused by granulomatous conditions like sarcoidosis, and also by various immunological conditions and occupational exposures. Then ATS again came out with another statement in 2011, and that is which permitted definitive diagnosis of idiopathic pulmonary fibrosis, that is cryptogenic fibrosis. That is usual interstitial pneumonia, where the fibrosis is the hallmark feature. Here, you don't have to do a lung biopsy to demonstrate fibrosis. You just do a CT scan. And if the CT scan shows your UIP pattern, that means you can make a diagnosis of, with confidence, the diagnosis of IPF. And then subsequently in 2018, the ATS came out with a further statement describing various radiological patterns which help us to say whether you have got a usual interstitial pneumonia, that is fibrosis, probable UIP, that is probable fibrosis, indeterminate, where you have inflammation versus fibrosis, or you have something other than this, alternate diagnosis. So that subset refinement was actually expressed in the statement of 8 years in 2018. So what is the prevalence of IPF, idiopathic fibrosis? It actually increases with the age. It's the disease which usually affects the middle-aged and the elderly people. Remember that. And it is more common among males than the female. And the prevalence is 80.9 for 1 lakh population per year. And then in case of female, it is 67.2. And incidence is about 31.5 per 1 lakh population. And in case of female, it's little less. And the incidence increases with the age. And there's normally the age-related fibrosis, which gets augmented with other, extraneous or internal factors. So now there are certain ILDs which are very common in women. One among them is lymphangioliomyomatosis. It is a malignant proliferation of LAM cells. Okay, the LAM cells, and that is, it leads to multiple cysts in the lung. So that is LAM, and this is common in case of females between the age of 20 to 40. And in case of males, we have similar type of situation that occurs among smokers. That is called the histiocytosis X, or Langerhans ILD. So here, you have the lung volume is preserved, but you have multiple cysts, and it is smoking-related ILD. So then there are certain connective tissue disorders like SLD. It's much more common in female than in men. And occupational exposure by virtue of the gender, certain genders, males are more involved in certain occupations. Therefore, occupational diseases are more likely in men. So what are the causes of ILD? I told you we have idiopathic variety, idiopathic pneumonia, which counts about 10 to 12%. And then we have remaining about 85% of cases where we have various causes which are responsible for this ILD. Then the 200 odd causes, the number may be increasing. And The classification of this classes itself is very challenging because there's overlapping of pathophysiological, morphological features. Because what is the end result of these cases? They all come with cough, they all come with breathlessness, and they have, they may come with pulmonary hypertension, right heart failure, or respiratory failure. But they may not, uh, give a definite history of occupation or connective tissue disorders, or they may have drug history or hereditary. So the end result is the same. Therefore, if you do actually the CT scan in these cases, or if you do what is called the biopsies in these cases, you may find only fibrosis here. They may not have much clue to the underlying etiology. So therefore, it is very challenging. So 12% of patients remain unclassified. That's I told you. They are called the idiopathic pneumonias, despite modern approach of early diagnosis and classification. But phenotyping is extremely important, my dear doctors, because that will is very important to give a very optimal and specified therapy in a given case. Now, this slide will tell you the various subtypes of interstitial lung diseases. Exposure related, that is occupation exposure. You can be exposed to organic dust and inorganic dust. Pneumoconiosis is exposure to inorganic dust. Silicosis, asbestosis, berylliosis. So these are some of the examples of pneumoconiosis. Then we have pneumonitis, hypersensitive pneumonitis, which can be acute, subacute, and chronic because of fungal allergy. Those who handle birds, who handle molds, storage and all these places, and then who deal with the pigeons. These are the people who are more likely to develop this type of problem. That is what is called the moldy fever or hay fever, or you may have what is called the acute allergic alveolitis, acute allergic alveolitis, where the patient may present with fever, severe breathlessness, neutrophilia for that matter, and there is no evidence of infection, but they have more of an allergic reaction, inflammation, and they can develop rapidly progressing respiratory failure. And these cases have to be treated with steroids, not with antibiotics. So then certain drugs like amidron, nitrofurantoin, PAS, sulfur drugs, then cancerous drugs and anti-cancerous drugs like bleomycin and all. So certain anti-epileptic drugs, all these drugs, can lead to interstitial fibrosis. And there could be a remote history of having taken drug. You may not develop immediate reaction. So one has to go into the drug history also. So these are the exposure-related interstitial lung disease. Connective tissue disorders, we all know, scleroderma, rheumatoid arthritis, Sjogren syndrome, unclassified connective tissue, mixed connective tissue disorders, lupus, myositis, polymyalgia rheumatica, so on and so forth, dermatomyositis. So these are the conditions which can present with ILD in various ways. There could be pleural involvement, there could be interstitial fibrosis, there could be lupus pneumonia, there can be pulmonary hypertension, there could be cardiac involvement. So you have wherever the connective tissue is there in the lung and in the heart, of course, they can be affected in different degrees. Okay. Then we have other conditions, vasculitis, venous granulomatosis, small vessel vasculitis, medium-sized vasculitis, polyarteritis nodosa. Then we have renal pulmonary syndromes, Good-Pastor syndrome, where you have a alveolar hemorrhage with a rapidly progressing renal failure. Then we have, as I told you, Langerhans histiocytosis, LCH, that is histiocytosis X, which is a smoking-related ILD, which occurs in males. Then pulmonary alveolar proteinosis, there's a dysfunction of the type 2 pneumocytes, and there is a dysfunction of the surfactant, and as a result of which you find that there is the proteinaceous material which accumulates in the alveoli, and they develop acute respiratory failure. Then we have eosinophilic pneumonias. It is again an allergic phenomenon. Large of eosinophilic pneumonias can also present with interstitial pneumonias, neurofibromatosis, hereditary-related disorders, then inflammatory bowel disease. So aspiration, microaspiration is another entity, especially middle-aged and elderly people who are obese, short statured, have narrow neck. And so these people, they have a tendency to have microaspiration. And this microaspiration, acid aspiration into the tracheobronchial tree can lead to intestinal fibrosis, one of the important risk factors. Okay, so then post bone marrow transplantation, immune reaction, so and there are so many conditions which can lead to ILD. Now, what is important in this slide is note down that idiopathic interstitial pneumonia, which is about 12%. So the most important one among them is the idiopathic fibrosis, what is called the UIP pattern. Then we have the discomatic interstitial pneumonias, the acute interstitial pneumonia, what is called the Hamandri syndrome. Then non-specific interstitial pneumonia, that is NSIP, which is a non-fibrotic interstitial pneumonia. Respiratory bronchiolitis, where there's involvement of this respiratory bronchos, which is getting obliterated, and then associated with organization of the lung. So I have a very solid lung, fibrous lung, what is called the BOOP, respiratory bronchiolitis with cryptogenic organizing pneumonia, bronchiolitis obliterans with organizing pneumonia called BOOP or COP. So then you have lymphocytic interstitial pneumonias and HIV and all, you can have lymphocytic interstitial pneumonia. So this is what you have to note. Now, I would like to emphasize another important ILD, tobacco-related. The smoking-related interstitial fibrosis is a relatively new concept. The CT scan has enabled us to classify, early stages of smokers. They can have interstitial fibrosis. They may not have symptoms, but you may find incidentally some fibrosis in the basis of the lung. It could be subclinical. Changes can be seen. Smoking triggers interstitial injury pattern. Already, our exposure to noxious agents and smoke, can result in alveolar injury. And if you continue to smoke, then it will perpetuate fibrosis. It will aggravate fibrosis. And then one of the clue for the smoking-related ILD is that there be emphysema changes. They are more common in upper lobes, emphysema, and lower lobe fibrosis. And other important feature is lung volume is preserved. Actually, in ILD, the lung actually constricts. Here, the lung volume is preserved because of the emphysema. But then, diffusion capacity is decreased. Diffusion capacity, then they have hypoxemia. And they have pulmonary hypertension because of hypoxemia. Now, we have different patterns. If a person has got respiratory bronchiolitis, has got discomative DIP pattern, pulmonary Langerhans, that is histocytosis X, and acute eosinophilic pneumonia, then you think of smoking-related ILD. Now, connective tissue disorders, here again, it may be the first manifestation, although it's not very common. They normally come with the systemic manifestation of connective tissue disorders. But some of the cases, they may not have systemic manifestation. They may not have joint pain, they may not have skin involvement, they may not have hair loss, they may not have mental abnormalities or repeated ulcerations. But they just may present with what you call cough and then, breathlessness or pulmonary hypertension. So this may be seen. And connective tissue related ILD are called by various nomenclatures, formi fruste, then CTD, lung dominant CTD, interstitial pneumonia with autoimmune features. Now, interstitial pneumonia with autoimmune features means they may not fulfill all the criteria of CTD, but they have clinical, serological, and morphological signs of autoimmunity. They have clinical, serological, and morphological signs of autoimmunity, but they may not classically fit into a CTD as per the, the classification of the rheumatoid diseases. So we have to have the right approach in the diagnosis and the management of ILD. If you want to actually exhibit some of these cases, the anti-fibrotic drugs or anti-inflammatory drugs. So that is very important. That is why I have been trying to emphasize this important point. Now, idiopathic pulmonary disorders, as I told you, they present with two classical features. One is we have what is called the non-specific interstitial pneumonia, NSIP. The other is frank fibrosis, the frank fibrosis. It is a frank fibrosis, what is called the UIP, usual interstitial pneumonia. That is the usual feature of a idiopathic pulmonary fibrosis. Therefore, it is called the UIP. Non-specific interstitial pneumonia means you have got more of inflammation, less of fibrosis. They have got a ground glass opacification. So these are the two hallmark histological features of idiopathic fibrotic disorders. Now, in India, when you talk of ILD, and which is often an underdiagnosed missed, is hypersensitive pneumonitis. The majority of cases of ILD in this condition is environmental related. That is, exposure to this fungus, the bird fancier's lung, those who handle pigeons, who handle birds, and who are exposed to these molds, the fungus. So that is responsible for hypersensitive pneumonitis. The presentation can be acute, subacute, and chronic. Many a times it's chronic. So, and they may not give the classical occupational history also. But then if you actually dig into the history, then you may get, the history of exposure to this, the allergens, like molds and fungus, etc. And the occupation they are dealing with, that history may be coming out. But then by the time the disease has reached the advanced stage and there are fibrosis. So in such cases, you are, subtyping and may not help the patient because the fibrosis has become relentless and progressive, And in these cases, even giving antifungal treatment or may not help. Now, what is the fundamental pathogenesis? The fundamental pathogenesis is there is injury to the gas exchanging units. There's alveoli, which has got capillaries and also which has got alveoli. So that injury leads to increased permeability, exudation, and of serous material into the alveoli and into the interstitium. And this inflammatory response is release of various pro-inflammatory, pro-fibrotic cytokines. And then the healing process takes place. There's a regeneration and reparative process. But in case of IPF, it is destructive and progressive and relentless. So it is almost like an autoimmune phenomena, the uncontrolled fibrosis. Even after the injury has been halted. That is the problem with it. Almost behaves like a malignancy. So this is what you can see here, that there's an insult, there's inflammation, then there is fibrosis and inflammation taking place side by side, and then you have an end-stage fibrosis. So, end-stage fibrosis, fibroblastic proliferation, excessive collagen deposition within the airways, that is in the bronchioles and also in the alveoli, in the wall of the alveoli, in the interstitium, and there is a distortion of the alveoli, there is a traction bronchiectasis, and then there's a destruction of the surface. So the surface area is reduced, so the diffusion of gases is affected. So it is going to have a very serious pathophysiological consequences. So interstitial inflammation, connective tissue deposition, reduced lung compliance, reduced lung volume, reduced tidal volume, rapid respiratory rate, rapid shallow breathing. Then they will have, reduced diffusion capacity. They have low oxygen hypoxemia, ventilation perfusion abnormalities, pulmonary hypertension, right heart failure, right ventricular hypertrophy, chronic heart pulmonary, and severe dyspnea, severe breathlessness. So this is the pathophysiology of the ILD. Now, When you do histopathological studies by lung biopsy or postmortem studies, then you find that the whole interstitium is infiltrated with the fibroblasts. The alveoli is all surrounded by fibroblasts. And if you do a CT scan, you can see all these things with the bronchiectasis, or you find the cystic lesions, and then you may find honeycombing. So that you can see. And if there's more of inflammation, then you may find ground glass opacification. You may find ground glass. So the hallmark feature is they have non-specific interstitial pneumonia, UIP pattern, where there is more of honeycombing and cysts and fibrotic lesions. Now, how to make a diagnosis? You have to take a detailed history, occupational history, family history, because there are certain young people, family history may be there. They may have some hereditary disorders, and certain families, the ILD is very common. So that where the genetic mechanisms operate, and the family history is very important. Then history of connective tissue disorders, vasculitis, and this may be there for several years before the onset of ILD, or ILD may be the first manifestation. They may not have a CTD with a multisystemic involvement as an obvious phenomenon at the time of presentation. Then occupational history, I told you, there are so many occupations, and some of these exposures can be deleterious to the lung, destructive to lung. Although we have tried to classify into various agents among these occupations responsible for ILD, but because of industrialization and because of the pollution, increase in the pollution, so there could be so many other chemicals and pollutants which may lead to subclinical progressive injury to the lung. So that is quite possible. So we have to take a detailed occupational history and to try to link up whether that occupation exposure related to the ILD. Drug history. There are a large number of drugs. As I told you, sulfur drugs, nitrofurantoin, amidron, anti-epileptic drugs, anti-cancerous drugs, they can result in bronchiolitis obliterans and also ILD, organizing pneumonias. Aspiration is another important. The gastroesophageal reflex, microaspiration is one of the important causes. And some people, they use nasal drops, the repeated nasal drops at night, these oily nasal drops mineral oils can cause, actually the ILDs. Smoking history, and as I told you, there are certain smoking-related ILD like histiocytosis X, respiratory bronchiolitis. 90% of these people will give the history of smoking. Goodpasture syndrome with alveolar hemorrhage, it gets aggravated because of smoking. Those who have Goodpasture syndrome and then who smoke, they are likely to get 100% alveolar hemorrhage. And alveolar hemorrhage means they may not have frank hemoptysis. They may have respiratory failure. And when you do a lavage in these cases, you may find a pinky sputum, and which may be positive for hemosiderin. So they may not have frank hemoptysis. And they're present with acute respiratory failure. And 20% of even non-smokers, who have a renal involvement, if the alveolar hemorrhage is very uncommon in non-smokers, but who have a Goodpasture syndrome. That's the point I would like to emphasize. The smoking enhances the alveolar hemorrhage. Tobacco use enhances development of fibrosis in asbestos exposure. There are asbestos exposure people who are smokers, they have 13 times higher chances of developing ILD. The incidence of sarcoidosis is, higher in non-smokers. Smoking is not a risk factor for sarcoidosis. So that is the point I would like to emphasize. So family history, IPF, sarcoidosis, tuberous sclerosis, neurofibromatosis, Niemann-Pick disease, Gaucher's disease, Hermanski, Pudlak syndrome, where there's a platelet dysfunction. So all these conditions can lead to ILD in certain family with a familial predisposition. Now, symptoms, the hallmark symptom is the breathlessness, which is progressive. And they may have dry cough. Dyspnea, therefore, is the most common symptom. But cough can be a prominent symptom when there's a small airway involvement. they have a respiratory bronchiolitis. Those have organizing pneumonias, histiocytosis X, Langerhans cell, hypersensitive pneumonitis, lymphangitis carcinomatosis. As I told you earlier, malignancy is not included in the cause of ILD. Today it is included. Lymphangitis carcinomatosis, where there's lymphatic spread of the malignancy from the alveoli. That is what is called the bronchial adenocarcinomas in the alveoli, especially in lipidic fashion, involves interstitium, and produces a lymphangitis carcinomatosis. And in these cases, they may have more of cough. Of course, they will have breathlessness, but cough is very predominant. Wheezing can be present when there's lymphangitis carcinomatosis, chronic use of pneumonias, respiratory bronchiolitis, hypertension. So if you get some of these, if you analyze the history, so if they have wheezing, you can think of these subtypes. And if their cough is predominant, then you think of these subtypes. Then if they have a substernal chest pain, it is an unusual complaint, and this is a common feature in sarcoidosis. Common feature of sarcoidosis. Then pleural trouble chest pain, it is common in connective tissue disorder because the pleural involvement can occur in these cases. It is not a feature of IPF. Hemoptysis. Hemoptysis occurs when there's a diffuse yellow hemorrhage, but it is more like an occult hemorrhage, where they have breathlessness and they may bring out pinky type of sputum, but they may not have frank hemoptysis. And lymphangioliomyomatosis, pulmonary veno-occlusive diseases, long-standing mitral valve diseases. So these are all conditions where they can have hemoptysis. So, and if they develop in a well-established ILD, if they develop hemoptysis, then you think of a complication like malignancy in these cases. Now, physical findings, you all know, you put the stethoscope at the basis, posterior part of the lung, you find typical Velcro crepitation, bibasilar inspiratory crackles. So when you take a deep breath, there's a snap opening of the small airways and the alveoli. So because of this, it produces a bursting type of sound. That is the classical bibasilar inspiratory crackles, which indicates that there is a snap opening of the stiffened airways, which is stiffened because of fibrosis. The crackles are less likely in a granulomatous disease. In the sarcoidosis and granulomatous diseases, it's not very common. And it may be present even if the chest X-ray is normal. Please remember, chest X-ray has got a very poor sensitivity. Clubbing of the digits is one of the important features that indicates advanced fibrotic lung disease. Okay. And there could be also other, it could be familial also. Or it could be because of underlying malignancy also. So clubbing is an important feature of IPF, but then it can be present if there's a complication by malignancy, and that could be hereditary clubbing also. That you have to keep it in mind. And when they have advanced fibrosis, they develop right heart failure, they have chronic pulmonary, they have features of pulmonary hypertension, and then they have other extrapulmonary manifestations. Now, clinical spectrum, it can be acute, subacute, and chronic. Acute, we all know, acute pneumonias, diffuse alveolar hemorrhage, acute hypersensitive pneumonitis, acute use of pneumonia, cryptogenic organizing pneumonia, acute exacerbation of fibrosis. So they may have fever. So you may think that it is due to infection, but it is not due to infection. It is due to hypersensitivity reaction, or it is due to acute exacerbation of ILD. Subacute and chronic, of course, is a hallmark feature of IPF. So here, the classical is IPF, sarcoidosis, chronic hypersensitive pneumonitis, occupational lung diseases, non-specific interstitial pneumonia, discomated interstitial pneumonias, respiratory bronchiolitis, lymphocytic interstitial pneumonias, chronic interstitial pneumonias. They all present with subacute and chronic presentation. Now, symptoms in patients with ILD are present a month to years. It is a very slowly progressing. They may have symptoms for many years. And progression may vary from individual to individual. Sometimes they may have acute presentation and they may develop complications and die, or they may not have acute presentation, but a slowly progressing disease for years and years. Several interstitial reactions can be acute and with fever and confused with infection that I already told you. Normal X-ray can be present in 5 to 10% of symptomatic ILD. And pulmonary function tests and exercising tests in these cases may unmask the disease. They may have some abnormality in the diffusion. There could be some decrease in the lung volumes, but the respiratory flows may be normal. So, or there could be involvement of small airways. The small airway disease means the mid flow, the expiratory flow between 25 to 75% of the expiratory flow may be decreased in these cases. So, early diagnosis is possible with HRCT in patients who have CTD, where you have to do bronchial lavage and do the HRCT. They may have normal X-ray. But in these cases, if there's a CTD, if you want to see whether they have a lung involvement, do HRCT, which can identify NSIP or fibrotic pattern. And also, we can also do lavage to identify inflammatory cells. So, asbestos exposure, hypersensitive pneumonitis, drug-causing ILDs, we can make an early diagnosis by comparing HRCT and BAL. So, HRCT is the most important thing. So, you have to have an understanding of what is called the secondary pulmonary lobules if you want to understand the HRCT. The secondary pulmonary lobule is a fundamental unit of the lung. It's a miniature of the lung, airways, pulmonary vasculature, lymphatics, and lung interstitium. So this secondary pulmonary lobule that you see here, it has got airways, it has got septa, it has got lymphatics, it has got vessels, everything is the miniature. So if there's any abnormality in the bronchioles or the abnormality in the septa, you can identify. The components of the secondary lobules are normally visible on a thin section CT. If you take a very thin sections of less than a millimeter thin section, CTs, then you can actually able to identify the secondary pulmonary lobule. This is a CT scan picture which shows bronchioles, which shows the septa, which shows the alveoli, so it shows the vasculature. So that you can see if you carefully. So depending upon the distribution of fibrosis, then you can say whether it is, you can subclassify and find out the etiology. So that is how the CT scan has revolutionized the refinement of ILD and subtyping of the ILD, depending upon the type of interstitial abnormalities and the distribution. Non-subpleural ILDs, where the predominant subpleural, where they don't have a subpleural localization. Then we have a subpleural non-fibrotic localization where they have ground glass opacities. Then we have a subpleural fibrotic opacities. So when you have a subpleural fibrotic opacities, which are in the lower lobes, not in the upper lobe, and they are more in the periphery, not at the center. So that is a hallmark feature of UIP or IPF. So distribution, there are certain lesions which are very prominent in the upper lobes like sarcoidosis, silicosis, cold workers pneumoconiosis, hypersensitive pneumonitis, histiocytosis, berylliosis, chronic illusion pneumonia. They are more common in upper lobes. Lower lobe, UIP, NSIP, then connective tissue disorders, asbestosis, DIPs, they're all more common. So if you look at the CT scan or the X-ray, if you find the upper lobe involvement more than the lower lobe involvement, then you can say that it is related to certain subtypes of ILD. Now, so distribution of ILD can also be, specified by what is called subpleural predominance that you can see here in this CT scan in the A. There's a ground glass opacification. Then in B, you find central predominance. There's a central predominance. Then in the C, upper lobe predominance. Then in D, you find the lower lobe predominance. So by looking at the CT scan and that distribution, one can actually, try to figure out the etiology of the ILD. So interstitial abnormalities, as I told you, It can be nodule, it can be fibrosis, it can be what you call the traction bronchiectasis, it can be honeycombing. So we have different types of abnormalities. Then there could be septal thickening. Now, so CT findings, you find the ground glass opacification. This is suggestive of NSIP pattern. Reticulation with ground glass opacification, where you have mix of NSIP and fibrotic picture. Then there's a distortion, volume loss, displacement of bronchi, traction bronchiectasis, with ground glass opacification and traction bronchiectasis. Then you have a traction bronchiectasis, predominant subpleural areas. Then you have honeycombing, demonstrating appearance with clusters of cystic lesions like this, which is a classical UIP pattern. Then non-emphysematous cysts can be present with well-defined walls. So here the walls will be very well defined, very well. So these type of cysts you find in lamb. So there is no evidence of fibrosis, but they have a well-defined cyst you will find. That is a feature of histiocytosis X and lamb. So now perilobular pattern differentiation, if you actually analyze the secondary pulmonary lobule, which have shown by the CT scan, then there are some lesions which are perilobular, that is involved, around the interstitial septum and the pleura. So whenever you have the pleural involvement of the septal involvement, then you think of pulmonary edema, hemorrhage, veno-occlusive disease, lymphangitis spread, sarcoidosis. So these are the conditions that you think of. So lymphocytic spread, then end-stage lung disease like sarcoidosis, interstitial pneumonias, peripheral lobular abnormalities. So this is what you have to see. You have to see whether there's involvement septum, whether involvement stairways, respiratory bronchioles, that is. Then whether or there's a random distribution. When there's a central nodule, the lobular nodule, that is around the bronchi, then bronchial infection, seen by the appearance, you must have heard about this terminology. So granulomatous infection, bronchopneumonias, infectious etiology, cystic fibrosis, then hypersensitive pneumonitis, diffuse planned bronchiolitis, histiocytosis, organizing pneumonias. These are various conditions where there is predominantly involvement in small airways. Bronchial spread of tumors, then angiocentric diseases, this is around the vessels, which are, around the small airways. So, which can result in pulmonary edema, pulmonary vasculitis. So that is what we have to look into. And when there is around the lymphatics, then you think of sarcoidosis, silicosis, cold work. Lymphatics are found around the septum. Please remember, this is present around the septum. So sarcoidosis, therefore you find the septal, lymphatic involvement. Now, so this is sarcoidosis. In sarcoidosis, there's upper lobe involvement, perilymphatic spread, and hilar lymphadenopathy. So if a hilar lymphadenopathy, upper lobe involvement, perilymphatic, you can say the cause of ILD is sarcoidosis. In lamb, you find the lung wall is preserved, but multiple cysts, it's not fibrosis, but multiple thin-walled cysts, there are cysts here. Then it can be complicated by pneumothorax. Now, in case of ILD, CT ILD, they have an NSIP pattern, and there is a low lobe involvement, much more common, and they may have traction bronchiectasis, they may have, ground glass opacification, and you may find cystic lesions or honeycomb. So those who are, you can have fibrotic CTD and NSIP CTDs, non-fibrotic CTDs. Now, when you investigate these cases, you may find leukopenia, leukocytosis, eosinophilia, thrombocytopenia, hemolytic anemia, normocytic anemia, urinary sediments, hypogammaglobulinemia, hypergammaglobulinemia, serum autoantibody, C-ANCA, P-ANCA positivity, immune complexes, suggestive of, connective tissue disorders, ANA, serum angiotensin converting enzymes, anti-basement membrane antibodies, anti-neutrophilic ANCA, positivity. So, depending upon the underlying etiology, you may have various lab abnormalities. Now, this is how to differentiate between various types of idiopathic interstitial pneumonia, how to differentiate RBILD, acute IA, interstitial pneumonia, pneumonia with NSIP pattern, cryptogenic organizing pneumonias, UIP. You see, you have to take into consideration the clinical features, then the lab findings, then the surgical biopsy specimen or HRCT. Based on that only you can differentiate these different types of idiopathic interstitial pneumonias. But as I told you, for the diagnosis of IPF, UIP, you don't have to do any surgical biopsy. If you have a classical honeycombing in the periphery, subpleural distribution, in the lower lobe, with a history of breathlessness, progressive, and then there is no any other underlying connective tissue disorders and all, you can definitely make a diagnosis of IPF without surgical biopsy. Mortality is contributed by various complications which occurs with ILD. So, for example, they develop respiratory failure. So that can account for 39% of the mortality among the IPF. And they can develop bronchial carcinoma, which can contribute to 10% of the mortality. Then they can develop cardiovascular complications, pulmonary hypertension, right heart failure, or thromboembolism, so many things which can occur. So that can lead to another 10% of mortality, or 24% of mortality. Pulmonary infection, they can develop secondary infection, and that can contribute to 2 to 4% of the mortality. Pulmonary embolism, I already told you. Pneumothorax, which can be a very serious condition. If it's not recognized, then they may just collapse and die. So therefore, that can also result and add to the mortality of the disease, that is IPF. Now, what are the drugs which are available? No, the drugs is immunosuppressive drugs, anti-inflammatory drugs. Now, the anti-inflammatory drugs don't have much role in UIP pattern. That is when you have fibrosis. When you have NSIP pattern, when you have inflammation, you have a connective tissue disorders. In such cases, you can use immunosuppressive drugs and anti-inflammatory drugs. Corticosteroid has been the main stay of treatment in these conditions, and it is used when you have a ground loss capacities, and you start with a dosage of 1 milligram, and then you give a maintenance dose of 0.5 and taper it and give a maintenance dose of 10 milligram. Then you may make it alternate so that the disease is in remission. Now, you have to take into consideration the various toxicities of steroids, like diabetes, affecting the vision, osteoporosis, then, peticle rashes, mooning of the face, hypertension. All these things should be kept in mind. And as far as possible, we have to give the minimal dose to maintain the remission. Azathioprine is another immunosuppressive drug which is used. It is used in connective tissue ILDs, hypersensitive pneumonitis. So in addition to prednisolone, you can use also mycophenolate, mofetil, you can use cyclophosphamide, or you can use methotrexate. So these are this one. Septron prophylaxis is used when you are suspecting PCP, and when they're on a long-standing, immunosuppressive drugs, and the CD4 count may be low, and they're prone to develop PCP. So you may have to cover up with Bactrim or Septron prophylaxis. The most important treatment for the ILD and IPF is antifibrotic drugs. At present, we have two antifibrotic drugs. One is nintedanib. It is an indolinone derivative, which is a tyrosine kinase receptor binding agent. It inhibits the fibroblast growth factors, vascular endothelium growth factors, and FMS, like tyrosine kinase factors. And because by inhibiting these factors, it restricts the neoangiogenesis, new vessel formation, and also the fibroblastic proliferation. So it prevents the fibroblastic activity by tyrosine kinase inhibition and by inhibiting the vascular endothelial growth factors and FMS like tyrosine kinase receptors. Now, dosage, it is available as a soft capsule. 100 to 150 milligrams is the dosage, which is given twice a day. And it is to be taken with the food. And it has got many side effects. When you have side effects, you may have to reduce the dosage of the nintedanib. The studies have shown that it is not going to cure the fibrosis. It may stabilize. It may not result in a rapid decline in the lung functions. The lung function may remain stable, but it is not a curative treatment. Please understand that. So you may have to give for 51 months, maximum 51 months people have tried. So various trials have taken place with 51 weeks of this particular drug. And they found that it's not going to reverse the fibrosis, but it's going to stabilize and there is no rapid decline in the lung function. So that is the only the good result of nintedanib. Now, adverse side effects, nausea, vomiting, diarrhea, pain, abdomen, loss of appetite, impairment of liver function with elevated liver enzymes, decrease in weight, skin rashes, cough can be there, respiratory tract infections, urinary tract infections, skin rashes, headache, fatigue can occur. So in such cases, you have to find out, is the symptoms very severe or is it tolerable? If it's tolerable, reduce the dose and do supportive treatment. Now, tobacco usage actually decreases the effectiveness of this drug. And also certain drugs, which actually stimulates the liver enzymes, which can also, affect the bioavailability of this particular drug. Now, pirfenidone is a derivative of pyridoxine. It's a synthetic. It is antifibrotic and anti-inflammatory activity. Nintedanib is antifibrotic, whereas this has got